To fit all of this into a quick, punchy explainer, we've chunked everything into 5 key sections. We've got hyperthyroidism and Graves' disease, hypothyroidism and myxedema, the 4 types of thyroiditis, diagnosing goiters and nodules, and finally, managing retrosternal goiters.
Section 1, hyperthyroidism and Graves' disease. We're kicking things off right at the metabolic extremes, starting with the overactive thyroid.
You really need to lock these diametric opposites into your memory. It's like a complete metabolic mirror image. Think of your hyperthyroid patient, right? They're thin, irritable, and even if they're sitting in a literally freezing room, they are sweating from severe heat intolerance. They're eating like crazy but still losing weight, and you'll probably spot fine tremors in their hands. Now contrast that with the hypothyroid patient. They're cold, lethargic, gaining weight despite hardly eating a thing, and usually complaining of severe constipation. Day and night, right?
Okay, looking at the hyperthyroid side, here's a classic exam favorite for you, the Jode-Basedow phenomenon. This is a critical one to remember when you're dealing with iodine. If you give a patient iodine and it actually induces hyperthyroidism, boom, that's Jode-Basedow. You've got to always contrast this in your head with the Wolff-Chaikoff effect, which is the exact opposite, iodine-induced hypothyroidism. Examiners absolutely love to see if they can trip you up on this, so keep them straight.
Moving over to Graves' disease, which is the most common cause of hyperthyroidism, we have to look at the eyes. And what's really fascinating here is the specific autonomic spasms that actually cause these Graves' eye signs. You will absolutely be tested on this. Signs like von Graves' lid lag and Dalrymple's lid retraction, those happen because of a spasm in Mueller's muscle, which is the autonomic part of the levator palpebrae superioris. And then there's Joffrey's sign, where there's no forehead wrinkling when they look up. That happens simply because the eyeballs are physically bulging out so far that their upper field of vision is naturally increased. They literally don't even need to frown to look up. Mind-blowing, isn't it? Next up is Plummer's disease. This is a toxic multinodular goiter, and it heavily affects females. We're talking a 5-to-1 ratio here. It's also the second most common cause of hyperthyroidism in America, right behind Graves'. Now here is a massive clinical pearl. Potassium iodide must be avoided in these patients. Why? Because you want to prevent triggering that exact Jode-Basedow phenomenon we just talked about. Giving them iodine can seriously backfire.
Before we leave hyperthyroidism, we have to talk about the absolute most feared complication, the thyroid storm. So what's the most common cause during surgery? The crucial takeaway here is that an inadequately prepared patient is the leading trigger for this deadly arrhythmic crisis. It's not about surgical rough handling. If you don't render that patient completely euthyroid using antithyroid drugs and beta blockers before you ever roll them into the OR, the stress of the surgery is going to trigger a massive uncontrolled hormone release. Arrhythmias are the leading cause of death here, which means your pre-op prep is absolutely non-negotiable. All right, Section 2, hypothyroidism and myxedema attacks. Let's pivot to the complete other end of the metabolic spectrum, the underactive thyroid. Pro tip for your oral exams or vivas? Always list your common causes first. It's such a common mistake to get nervous and blurt out some ultra-rare syndrome. Start strong. Highlight that iodine deficiency still absolutely rules as the #1 cause of hypothyroidism globally. But if the question specifically asks about the Western world, your answer needs to shift immediately to Hashimoto's thyroiditis.
Section 3, the 4 types of thyroiditis. Speaking of Hashimoto's, let's look at the inflammatory conditions that actually trigger these metabolic extremes.
Consider this table your ultimate cheat sheet. It maps out the precise clinical differentiators across the 4 major types of thyroiditis. You've got Hashimoto's and postpartum, which are both autoimmune. Then there's de Quervain's, triggered by a viral infection. And finally, Riedel's, which is an IgG4-related fibrosing condition. You really want to pay close attention to the key features here. Things like pain, ESR levels, and gland texture. That is exactly how you're going to tell these apart in the clinical vignette.
9. That number is huge. It represents the 9 times increased risk of Hashimoto's thyroiditis if a first-degree relative has it. That is a massive hereditary link. Yes, it's an autoimmune condition associated with HLA-DR3 and B8, but if you've got a family history, your risk absolutely skyrockets.
Now let's talk about hashitoxicosis. This concept perfectly explains why Hashimoto's patients actually present as hyperthyroid at first before crashing into permanent hypothyroidism. Basically, autoantibodies stimulate lymphocytes to infiltrate the gland. As those lymphocytes ruthlessly destroy the thyroid follicles, all that stored up thyroid hormone gets dumped directly into the bloodstream. It creates this transient, highly toxic phase. But since the follicles are completely destroyed and can't regenerate, the patient eventually plummets right into prolonged, lifelong hypothyroidism.
So the really critical comparison here is between the painful viral nature of de Quervain's and the rock-hard, painless presentation of Riedel's. If a patient walks in with a painfully enlarged neck right after an upper respiratory viral infection and their ESR is elevated, you're looking at de Quervain's. Thankfully, that one is self-limiting because the follicles do regenerate over time. But if a patient presents with a painless, woody, hard thyroid, you've got to think Riedel's fibrosing thyroiditis. Because it's so incredibly hard, it clinically mimics anaplastic thyroid cancer. That means you absolutely have to perform a true-cut biopsy to rule that malignancy out. No exceptions.
Section 4. Diagnosing goiters and nodules. Let's transition into these structural swellings and the exact step-by-step diagnostic pathways you need to take.
First things first, getting your terminology straight between isolated and dominant nodules is essential before we even touch malignancy risks. If you feel one distinct lump and the rest of the gland is completely impalpable, you've got an isolated nodule. But if you feel one prominent lump and you can also feel the rest of the enlarged gland around it, that's a dominant nodule sitting in a multinodular goiter.
Look at how the physical characteristics of a nodule dictate your level of clinical panic. The risk of malignancy is vastly higher in males across the board. An isolated solid nodule in a male patient, that carries a massive 48% risk of malignancy. That is basically a coin flip, and it demands immediate attention. Even a cystic isolated nodule in a male sits at 24%. Now, females generally have about 1/4 the risk compared to males in these categories. But listen to me, an isolated solid nodule always warrants rigorous workup regardless of gender.
All right, here's your gold standard step-by-step approach to any thyroid nodule. You always start with thyroid function tests, specifically TSH. If the TSH is abnormally low, send the patient straight for a radioiodine scan to look for a toxic, hyperfunctioning, hot nodule. But if the TSH is normal or high, you move to step 2, an ultrasound, where the nodule is graded using the Thyroid score. And based on that score, step 3 is an ultrasound-guided fine needle aspiration cytology, or FNAC. This categorizes the cells using the Bethesda system, which definitively guides your surgical management. It's a beautiful, logical algorithm.
Section 5. Managing retrosternal goiters. Finally, let's talk about what happens when these structural goiters decide to dive down below the collarbone.
So, a retrosternal goiter goes behind the sternum and right into the mediastinum. The big distinction here is where it actually started. Primary retrosternal goiters are pretty rare, only about 10% of cases. They arise from ectopic tissue already in the chest, so they get their blood supply from mediastinal vessels. But 90% are secondary plunging goiters. These started in the neck and just grew downwards over time, meaning they still get their blood from the neck vessels. And guys, this is a massive anatomical advantage because it means they can usually be pulled right back up and removed through a standard cervical neck incision.
Now, eliciting the Pemberton sign is a classic bedside maneuver. It helps you instantly spot a retrosternal goiter that's compressing vital structures. You just ask the patient to lift their arms above their head. If they have one, the goiter gets pulled up into the thoracic inlet and acts exactly like a cork, obstructing it. The venous return gets blocked, and you will see immediate facial and conjunctival congestion. It's a really striking clinical sign.
Like we said, most plunging goiters are safely removed via the neck. But you absolutely must memorize these 3 specific indications where cracking the sternum, doing a median sternotomy, is strictly required. You have to open the chest if it's a primary mediastinal goiter with a chest blood supply, if it's a large, malignant retrosternal mass, or if you're dealing with a recurrence that's isolated down in the mediastinum.